Um, I know we're running a little bit late, and I'm sorry, but I want to take a moment to introduce our last speaker, who I am so glad she's here for many, many reasons. And this is Dr. Sarah Cohen Solomon. Dr. Cohen Solomon is a board-certified pediatrician, and she's a specialist in hypermobile EDS and its related conditions. You may have seen her on Instagram because she's on there quite a bit and has a huge following. And we're hoping that she's going to help us here anyway with that. But we are overjoyed to welcome her here to UVA. She's actually new on our faculty. She started actually this week. So we're really happy to have her join our team. And she's going to start seeing patients with EDS in our hypermobility clinic. Her work basically focuses on diagnosing and managing complex pediatric conditions, including dysautonomia, mast cell activation, and obviously everything that goes along with it. Okay, so Sarah.
Okay, let's see if I can figure out where that 3 o'clock was then. All right. Nope, hold on. Help.
So forward.
Okay.
Reverse. This one right here. So go black, just hit forward again.
All righty. Thank you for sticking close. All right, so that is me. I'm also the Bendy Pediatrician online. I created the Bendy Pediatrician, which I forgot to put the name of up here, at a time when I needed a bit of a creative outlet because I was distressed at how few voices were out there in social media from a medical standpoint. There's a lot that is magnificent from a lived experience standpoint, but I bring both, and I thought maybe I could help a little bit. And it catapulted out of hand very quickly, not to my mother's surprise, but to my surprise, and I'm very proud of it. And I want to talk to you about why, because I'm a pediatrician, unlike most people who specialize in these conditions. So I do want to focus very strongly on the diagnostic odyssey, because I think that launches how difficult this life is for so many of us. And I want to make sure that anyone who happens to be in healthcare related to children understands how to recognize signs early. And I'm going to talk a little bit about most types of EDS, and understand where the criteria does well, where the limitations exist, what can be done to improve this in the future. And it's very important that we talk a little bit about the red flags that might be related to medical child abuse. This is the worst part about pediatrics. It is a reality of life, and it's very important that anyone who has unusual signs and symptoms knows about this topic. So we're going to talk about that, but I do want to preface it with a trigger warning and a content warning, because this is heavy. And we are also going to be talking a little bit more thoroughly about that in advance of screening the film Complicated after my discussion. But all that being said, I am a very hopeful person, and we were worried collectively that people would leave this feeling down after such a heavy topic, which is fair. But instead, I'd like people to look at this discussion as something that can be changed and can be improved on, and this is our charge for the future. So think of it that way as we go through here. All right, the diagnostic odyssey. Shout out, as a parent or as a clinician, what do you guys think I get asked the most about EDS? Don't be shy. It's the end of the day. We got this.
How can I make my kid not like me when she grows up?
That's a good one. That's a good one. What questions do we think other than that? A little more straightforward. Sure. That's a good one. The one I hear most, how do we recognize it? Which is actually great, because it used to be, what is it? That's better. There's this thing that happens. I've started recently calling it the recognition paradox. Show of hands, who's heard the phrase, if you hear hoofbeats, think horses, not zebras? Yes, the whole room for those at home. So this concept is good in theory. I saw that in the back corner. In theory, the concept is good. We don't want trainees or any clinician to be assuming everything is uncommon that they're looking at. We want to think first of the thing that's most likely in front of us as a diagnosis. That's reasonable, that's good. But we don't teach this in a way in which students then remember to think that a rare thing might actually be in front of them, because the doctor's office is where people with symptoms are going to go. But we teach it wrong. So we end up with this thing where we say, oh, well, I learned that that symptom or that sign or that condition is rare. And if I think something is rare, it's probably a zebra and I'll probably never see it. So it's probably not what I'm seeing. And then something becomes common and we say it's not important. Where does that leave our patients? So by no means is this comprehensive. Dr. Francomano, who I've known a very long time, did a beautiful job explaining the diagnostic criteria for the more rare genetically defined types of EDS. I'm not going to pretend to be on her level. But what I wanted to point out is that in any well-child exam, we as pediatricians are trained to recognize various signs and symptoms that are likely to be genetic in origin. I had really, really great physicians training my class of residents, and one brilliant man said, if you see 2 or more craniofacial or malformations or things that don't make sense and look different, go to genetics. And I thought that that was very wise because geneticists are trained to look at things from that perspective. So any well-child visit with any clinician should be able to say if a child has skin fragility plus unusual facial features or something else on this list, that might need evaluation with genetic testing. Now, I neglected, unfortunately, to put a slide in about social determinants of health, by which I mean everything about your environment affects how you actively access medical care. So if you are in the middle of a farm in Idaho, you are not going to easily be able to find, say, a mast cell specialist. I know that because I'm helping the Mast Cell Society do that research, but we could all probably have guessed. But in theory, we're trained to recognize things like this as needing genetic evaluation. So again, we have symptoms that are potentially visible at birth and distinguishable as not supposed to be there on a well-child exam, respectfully. So hypotonia, low tone, kyphoscoliosis, hip dislocations. Every single pediatrician in the country is checking for a hip dislocation. But even when we have a genetically defined version of EDS, we're still not getting the diagnosis right early, and it's dangerous. So this was a study very recently in which they were looking at what's called the major first event. Oh, I have slides over here now. I can stop craning my neck. Great. Gotta walk the walk, right? So I'll be back here now where I'm not hurting myself. Very good. Anyways, so vascular EDS, genetically defined, still rare. And this study was looking at age at first major event, so rupture of an organ or an artery, an aneurysm, et cetera. And one very important piece of data was that the initial event ranged in their data pool from age 14 to 75. 14 is pediatrics, just to be really bold about it. 14 is pediatrics. We'll start there. But the median age at genetic diagnosis was 41. That wasn't the same person, just to be clear, but the range is important. So this study was looking at both index patients, which is to say the individual who had the event, and their relatives who were diagnosed with genetic testing after the relative had the event. And they had physical traits that could have been seen before the event. 50% of them had those physical traits that could have been helpful in diagnosis, but they weren't. They did find, so these are just a glimpse of what vascular symptoms look like. So easy bruising, acrogeria, so hands looking older when they shouldn't, thinner translucent skin, hip dysplasia, again in the fragile gums, just a sample, not comprehensive. But I thought was interesting, the major events were not more frequent when they had the visible symptoms, but they did happen earlier. So things that could have been picked up on younger with awareness weren't, and those individuals were more likely at risk of having an event younger. And interestingly, it happened more in men, which is not what we usually talk about in EDS. My favorite part about this is that there was something that could be done about it. So they found in their study, they were also looking at hypertension amongst these individuals. To nobody's surprise, with hypertension, the first major event was younger, but not without hypotension. So of course, very reasonably, they recommend blood pressure monitoring. Any guesses? Feel free to cheat. How many studies do we think there are in children with VEDS? Very good. None. I like preventable problems. So when we're comparing the hypermobile type / HSD, I am of the opinion that they're the same thing. Please forgive me if I say it that way. It's a lot of letters. Versus CEDS or CLEDS. This was a study done in Germany looking at age of diagnosis amongst many other things. They took a study of almost 100 adults and took a look at age at symptoms versus age at diagnosis and how long that took. For CEDS and CLEDS, this was 5 years old when symptoms first started and 10 for HSD or HEDS. Age at diagnosis was 20 and 34. So the longest, and median was 23 years to diagnosis. That is a very long time. And this is just one study. They're not all identical, but they're all bad, which is to say it's too long, right? But what was also interesting here, and you'll see in the other papers as well, how many incorrect diagnoses are given first. I'm shocking no one in this room, clearly. But also, they really flocked to other resources. And I mentioned before that I launched the social media stuff that I do because the resources aren't available, with the exception, of course, with our colleague Linda Bluestein, because she felt the same way, I imagine. Because our patients, 63% in this study, are flocking to other resources because they're not available through traditional means, which is to say, their doctor. Let's talk early signs. That's me, demonstrating the W pose. 500 patients surveyed about 3 years ago. They were looking at the big question: what do you see first? What is the big symptom that you see first in your child or that the pediatrician notes first? Pain and fatigue. That's the reason for seeking care. Again, 23 years before you actually get a diagnosis. With an average of 15 clinicians seen before a diagnosis. About 24% of the people surveyed said they had seen more than 20. I'm going to return to the concept of doctor shopping later. It's a phrase that I would love to disappear from the lexicon. It's a horrible phrase, and I'm going to talk more about it. But this is what is often meant, seeing too many doctors to try to get your diagnosis. For those at home, I'm putting air quotes in. I do not actually mean that. But in this study, official diagnosis was 57% made by a geneticist, 20% by a rheumatologist, and only 5% by primary care. And again, we have a very long time to diagnosis. And again, 10 diagnoses that were either wrong or muddled the works. To me, this reads as a gap in medical education, because I'm someone who likes to go back to the core of the problem or the source of the problem. So when I was training, I can tell you with certainty it's limited, it's inaccurate, it's discriminatory. My board's review course had one 5-minute chapter, if you will, with a video of a rheumatologist who stood in front of the students and said this was videoed and used for years. She said, oh, those people with EDS, she didn't specify which type, they have like the ability to dislocate on command and it doesn't hurt them. And if I'd had time, I would have cried about it, but I didn't have time. I was studying. So instead, I sent a polite but angry email to the board review course. I never heard back. But a Delphi study after I took the boards in 2025 was looking at what do we think of the rheumatology requirements for general pediatricians? So for those not in medicine, in general pediatrics, we have to study a lot of different subjects, including rheumatology. The rheumatologists got to decide what we needed to know as general pediatricians. And this study was reviewing what we thought of what they wanted us to know. I hope that made sense. And essentially, we general pediatricians thought they did not put it together very well. As written here, this is a direct quote. It's not clear what is encompassed with topics like connective tissue disease. What does that mean? That's my part. That's my commentary. So they lumped in, this is all they said, such as, I'm quoting for those at home, Marfan syndrome and Ehlers-Danlos syndrome. That's it. That's what they said. The only other reference to hypermobility in the entire, I think it was 25 pages, was that pediatricians should be able to do a joint exam, a physical exam on joints, and distinguish between normal / hypermobile or inflammation. I don't know what they meant by that, but that's the quote. The only other time that general pediatricians are usually interacting with the concept of hypermobility is the pre-participation sports exam, which is to say before kids are allowed to do sports, you have to sign paper and it gets, lengthy. Somewhere buried in the middle of the AAP form is the word hyperlaxity. That's it, that's the whole thing. That's all the screening we do in pediatrics. But if you're really lucky, you have attending physicians who teach you the difference between hypermobility and instability, and that while the Baton score is lovely, sort of, in that it's fast, it's not that accurate, and we've talked about that a lot in the last 2 days. Fortunately for pediatrics, it seems to be most helpful for generalizing hypermobility in our ages, so age 6 to 12. It's still not great. There are a lot of features that affect this. I don't think it's very accurate for sex. There's a lot of new material coming out about gender nonconforming in individuals who may or may not be on hormones, changing how their joints do. So this has not been studied adequately. It is skewed to the upper extremities. And if anyone's squeamish, I'm really sorry about this. If you have a joint that is slightly dislocated at all times, you can push it maybe this far. If you put it back in place, it will go much further. And to me, that is 10 seconds to disprove how well the Baton score works. Sorry. So let's talk about some breakthroughs, but remaining limitations. Before some recent updates, so this is in 2009, this was around the time that I got diagnosed, maybe a year or two later, and what I really enjoy about this flowchart, because I love a good flowchart, is, I don't know how to turn the thing on, it goes in a circle. It goes in a circle on the side here to try to find the answer of what kind of hypermobility is going on here. And the authors of this paper are people I know. They did try their best, but there was nothing to go on at the time. And I know that because I was the age bracket, and there was nothing to go on. When I was diagnosed 20 years ago by Dr. Tsouporis, who was a good geneticist going off of what he knew at the time, his name was on the 1997 criteria. So this is for my mother who is watching. When my sister and I were diagnosed at that time, she asked, hey, does this explain the GI stuff that my twins are experiencing? Because we were both diagnosed with EDS at the same time. And he said, no, it only affects the joints. So when the American Gastroenterology Association came out with guidelines, 3 months ago, something like that, saying, hey, if you have a patient with HEDS, check these things that affect their gut, I printed it and handed it to my mom with a little like, congratulations, you were right 20 years ago. So between that time and 2017, we did our best with very limited information for pediatrics. From 2017 onwards, when we had the adult criteria, which Lara Bloom discussed yesterday, so I won't go into in detail, we did our best extrapolating from that. But it wasn't for us, it wasn't for pediatrics. So in 2023, the international working group, the international consortium got together and tried to make it better. And in a lot of ways they did, and in a lot of ways I think the future is going to hold even more. So the goal was now to have evidence for the age brackets we were looking at, which is obviously a good goal, and to make it a, I'm not sorry for this pun, flexible spectrum for monitoring, largely so that we didn't lose patients who needed to be monitored but didn't have all the symptoms, all the signs yet. This is obviously a good thing, and to a degree, and I'll show you, there's a beautiful little flow chart in a second, how that is helpful. So that acknowledgement is great. We lose fewer kids who then will spend 20 years being like, well, they told me 20 years ago I didn't have it, so I believed them. Well, hold on, maybe we just don't know how to recognize it yet. The downsides to this new set of criteria is that, first of all, I think the names are very confusing. I think they were a great step in the direction of acknowledging that not all people have the same symptoms, and that is very, very important. But they don't have their own codes yet. It's all nestled under hypermobility, whatever. And that doesn't give me data. That doesn't tell me what I'm looking at if I see that code on a chart. And it implies the need, you'll see in a second, for reevaluation when you're done growing or turn 18. Because what they did is they said, hey, let's nestle everything pediatric under HSD and say that you can't be called HEDS until you're done growing or turn 18. And I think that it was well intended, but I don't like it personally. And I think that it gives us a valuable framework for not dismissing, but also I think in the future we'll all look and say, hey, maybe we need to do some more. And that's the whole point of science, by the way, guys. Science changes. We got to keep going. So if anyone wants to look at the framework, by the way, this is a QR code. It should work. But I like a good flowchart. This gives you a pretty easy to follow way to understand how the new on this page. I'm not even going to try with the laser, did I? Oh, I got it. Haha. I'm easily excitable. There we go. So here's our framework. Ta-da. And that translates into this flowchart. What's confusing, of course, is that this column here are all the new diagnoses, and they all sound alike, and that's kind of hard for the brain fog. So step in the right direction, more to do, such as science, because this stinks, right? This is hard. And it's in line with what adults are seeing. They're not 30 when symptoms like this happen, when you're involving I have so many nods. I'm so sorry. They're teenagers. They're teenagers. This was at a low point. I drew that of myself in medical school because health-related quality of life is important. I had dislocated both of my kneecaps, and I was facing expulsion if I didn't pass my boards on the third try because I kept dislocating things before the test. And there was one individual who thought that meant I shouldn't graduate. She's not in that role anymore, don't worry. But this is how I felt at that time. And I think it demonstrates how a lot of us feel at some point. Don't worry, I'm here, it's all right. But in these patients versus controls, health, quality of life based on health is lower. That's fixable or addressable at the very least. Physical, emotional, school functioning, they're out of school. If any teenagers are listening or parents of teenagers are listening, I missed my entire senior year of high school. So we can go back and get back on that conveyor belt, all right? Fatigue, pain scores, all the main predictors. We already talked about sleep with Dr. Pasinki. And unfortunately, these patients are turned away from primary care because we are too complicated, because we are not teaching people how to look for this and make it not complicated. Because we need multidisciplinary. We need people involved. You're given 15 minutes. How are we supposed to do that? And what I want pediatricians to be able to see is that if you know what you're looking for, if you know what you're looking at, it doesn't have to be this complicated. It's a lens. It's a lens. And this is going to sound really goofy, but this really helps to understand it. If you look at it through a lens, not pathophysiologically, but just logically, think of your connective stuff. Your glue in your body is Laffy Taffy and it's melting. How might your body react to that? It's not going to do the normal things. So stop thinking it's going to do the normal things. It's going to do all the abnormal things. That changes your entire way of looking at everything, and it actually makes it easier. This is where the trigger warning and content warning happens. If anyone wants to look away or step out, that is completely all right. But we need to talk about medical trauma and gaslighting, or we are doing not an adequate job. There are a number of studies coming out now that I won't go into detail on because I'm over time, talking about how much this population suffers before it is, if it's ever acknowledged. We are diagnosed with factitious disorders, secondary gain, and child abuse. I have more on that in just a second, and it is not okay. There's a new term coined by several colleagues of ours, clinician-associated traumatization, which I think really needs no explanation in this group of people. I also drew that because I was feeling bitter and silly about it, so. All right, medical child abuse. We are taught appropriately to look for unexplained bruising, soft tissue injuries, fractures, dislocations, things that don't fit the pattern that makes sense. And we should be trained for that. And also we should be trained to know what types of EDS look like. I'm not going to go into these details. You can see them. They're essentially taken off of the very well-organized Ehlers-Danlos Society page on concerns about child abuse. Please take a look at those in detail. But it's important to understand that just because it might sound like medical child abuse doesn't mean that it is. Which brings me, unfortunately, to the elegant but heartbreaking film that we're going to watch after I'm done, called Complicated. And we are lucky enough to have Donna Sullivan here with us, who's become a good friend. She has taken the last 9 years to produce this beautiful, heartbreaking film. born from her own family's experience, and then more and more unraveled as they were going along. You'll see as we go, that relates to people not understanding what we're dealing with. So in an excellent paper by Lee and Chopra just a year ago, almost 95% of patients with EDS, and they were looking mostly at HEDS, but EDS in general, were misdiagnosed first. 67 diagnosed incorrectly with a conversion disorder. Only 6%, almost 6%, had not been diagnosed with a psychiatric illness. We are told we're making it up. We're told we're seeking attention. We're told it's all in our head. These numbers are unacceptable. And while we were having dinner recently, I was on a little tirade about this, and I looked over rhetorically at Don, and I said, do you even know how rare what's used to be called Munchausen's by proxy is? And of course she answered, because she knows, it is way more rare than HEDS. And yet, what is this? That we have this paradox where if it's rare or doesn't fit the pattern, that means it's medical child abuse. I got a little antsy about numbers because I do that. And I just wanted to see what's out there, because I hate that we don't know more. We should know more. We're doctors, we're curious. We should be curious. So I just typed into PubMed, Ehlers-Danlos and Pediatrics, 300 papers. Ehlers-Danlos Pediatrics treatment, 79 papers. Arthritis. So juvenile idiopathic arthritis we're tested on that constantly in pediatrics. 8,500 papers. Almost 4,000 papers with treatment. If we believe newer numbers on HEDS and HSD, it's a similar prevalence. So we got to get there. So what if, instead of diagnosis in adulthood, we diagnosed there? What could we prevent? Lee and Chopra really said it far better than I can. Misdiagnosis of Ehlers-Danlos syndrome is a pervasive issue with profound implications for patients' physical, mental, and economic well-being. By addressing the underlying causes of misdiagnosis and implementing strategies for improved recognition, the healthcare system can significantly enhance outcomes for individuals who are affected by these complex conditions. And that, my friends, is why we are here. I'm not sorry for going over, but I thank you for your patience. This is hard, and it should be hard, and I'm so glad that we are here, and I'm so glad to have joined these wonderful people for this incredible, I don't know, adventure, airplane ride. What are we on? And I can't wait to see what we make. Thank you so much.
Thank you so much, Sarah. That was wonderful. And you know, as a pediatrician, I'm just really glad you're here. So, because this is I've been fighting an uphill battle just with all of this information.
You have a
it's
team
really
now.
important. We have a team. So, any questions for Dr. Cohen Solomon? Yes.
Hi, I'm Taylor. I'm a sports medicine physical therapist, and I'm doing sports screenings in a month on kids. So I
Sports
typically
screening, yeah.
use the Baton scale, of course. Do you have any recommendations that I should look out for besides the Baton scale that I could use? I have probably like 30 seconds to a minute with these kids while I'm screening.
Ask more about history of injury and whether or not they have trouble keeping up with their peers, because I also don't want to keep them out of sports if they're enjoying sports, or like pretend a problem exists before it really does. I'd rather we watch them and make sure that they're learning how to use their body effectively, refer back to previous talks. But we can certainly get into more details. You can email me. Yeah.
Thank you.
Yeah.
One last question.
There was the genetics department inside of pediatrics that worked with adults and EDS. Can you explain how these things, what's happening to these departments?
I've been here 2.5 days, so
Yes,
I'm going to turn
can't
over.
really
to Ina.
answer that. Can't really answer. Our genetics department is housed in the Department of Pediatrics, and they do see. I'm sorry. The question was, how is the structure of our genetics department here at UVA structured? Is it peds? Is it adults? Who takes care of who? It is in the Department of Pediatrics, and they do have pediatric specialists, and they do have trained geneticists to adulthood. But, and so they will see adults, and there's different branches of it. We could talk offline about it. It's a little bit too much to go for, and Sarah, she doesn't know the structure of the department.
But I will soon.